All right, well, the recording's kicked off, so I think since it's 12 o'clock, just to let everyone know who is watching that this will be recorded and the session will be uploaded to YouTube. So if anyone does join late, they'll have a chance to catch up later on after the session. So in the interest of time, I think I'll just hand straight over to Vicky from the Christie to introduce John's lecture for today.
Thank you very much. So I'm Vicky Sharples, Chief Nurse at the Christie. So it's an honour to introduce Professor John Murray as he delivers his MAHSC inaugural lecture today. John's appointment as a MAHSC Honorary Clinical Chair is a significant achievement, not only for him personally, but for the Christie and the wider nursing profession. MAHSC Clinical Chairs are awarded to individuals who've demonstrated exceptional clinical leadership, research excellence and sustained contribution to improving patient care. They are designed to strengthen the partnership between frontline clinical practice and academic innovation, ensuring what happens in clinical practice directly influences education, research, and future clinical standards, and vice versa. For a senior clinical nurse to be awarded such title is especially important. Nursing voices are essential to shape the future of cancer care, yet remain underrepresented at the highest academic levels. John's appointment is therefore more than just a personal accolade for him. It's a powerful recognition of the impact that highly skilled research active nurses have on patient outcomes and service improvement and the global development of specialist practice. It sends clear messages to expert clinical nursing that it is central, not peripheral, to innovation in oncology and transplantation. John embodies all of these things. Over the last 3 decades, his career has been a model of excellence, compassion and leadership. Beginning as a registered nurse in Liverpool, he's become a highly respected transplant practitioner nationally and internationally. Since 2007, he's served as an advanced practitioner in the Haematology and Transplant Unit at the Christie, and more recently, our advanced practice education lead. Our advanced practice lead for the organisation, full stop, he is our lead advanced practitioner, in which he influences thousands of patients that experience their care under advanced practitioners. His academic contribution is exceptional. His extensive portfolio of publications, including chapters in multiple editions of European Society of Blood and Bone Marrow Transplantation handbooks and textbooks, materials downloaded and used globally as core references in the profession. He's helped write and shape international guidelines, and he's also chaired the European Society of Bone Marrow Transplantation Nursing Group. John's passion for education is remarkable. He's taught across universities, developed simulation programs, created regional advanced practice teaching forums, and supported international trainees from multiple countries. He has always championed accessible, evidence-based education, ensuring staff are confident, skilled, and equipped to deliver the highest possible cancer care. What sets John apart is what is achieved whilst remaining firmly grounded in clinical practice. He's visible and a visible, present clinician whose work is shaped by the realities faced by patients and clinical teams every day. His professorship therefore represents the very best of what academic clinical leadership can be. He's rooted in practice, driven by excellence, and always focused on improving the lives of patients. At the Christie, we could not be prouder of John. His expertise, his humility, his generosity with his colleagues, and unwavering dedication to patient-centred care make him an exceptional role model and ambassador for our organisation. It is a privilege to introduce Professor John Murray today.
Well, thank you very much for your really kind introduction there, Vicky. And I'm really grateful for this honour of the award of Honorary Clinical Chair. And I'd like to thank Pete and the rest of the team for inviting me here today to talk about my own personal roadmap here. I'm not really sure if it is a roadmap that others could use. It's more of a sketch of a really random winding path. But I hope that along the way, there might be some pieces you can take with you on your own journey and hopefully not get too lost. I occasionally get lost when I'm out in the hills. I love this slide and I use it a lot. And that's because I don't, but I am. I really don't have special talents, but I am really, really curious. And that gets me to a lot of places and sometimes a bit of mischief. So how did I get here? I think like a lot of people who are going to do these lectures over the next few months with a lot of help, guidance, support, and an occasional, what on earth are you doing, John? And I really want to thank everybody who's been a part of that across my journey. And that's all of the patients, the staff, everybody I've worked with in those different forms. But most importantly, and the biggest person I want to say thanks to is really Dawn. And yeah, thanks for that. So, you know, Vicky's introduced me there. My name is John Murray. I work at the Christie in Manchester, and I'm a nurse, and I've been an advanced practitioner here at the Trust for the past 18 years. And I've worked in haematology and transplant now for the past 35 years. And within this time, I've had a variety of roles and an awful lot of titles. And I now have a joint appointment working clinically within the haematology and transplant team. And I also work as the advanced practice education lead for the Trust. Where did it all start? It started when I had hair, and you know, I don't have hair anymore. So I grew up in the West Midlands in a small town called Bedworth, and that's probably the nearest place people might recognise is Nuneaton. That's on the train line. That's a few miles down the road. And at school, I wasn't very academic at all. I love reading, and I used to read an awful lot of everything, really. But I was absolutely terrible in exams. And I scraped through 7 O-levels, just about managing grade C in all of them. I managed then to get through to do some A-levels. And during my A-levels, in the end of that first year, you had to do a workplace based placement, and I chose to do that. I wanted to do something medical, but I really wasn't sure what to do, so I chose to do that at the local hospital, a place called George Eliot. And when you volunteer, you just get placed somewhere, and I got placed onto a children's ward, which was just absolutely amazing. I was watching the way that the nurses interacted with the children, and after 6 weeks of doing that, I ended up then applying to be a nurse. That really shaped what I was going to do. I got accepted onto a nursing programme at the Royal Liverpool Hospital to start on the 18th of January 1988, and that photo is from February 1988, so a young 19-year-old not really knowing what's going to happen next. When I got accepted onto the course earlier in '87, I was still doing my A-levels, but obviously had not taken them at that time. So I managed to spectacularly fail all 3 of my A-levels. That was really down to a mixture of just having far too much fun as a teenager. I had 3 part-time jobs at the time and a car and an awful lot of energy. And the fact that I've been given a place at nursing school already, in my own head, I really couldn't focus to take exams that I already knew I didn't need because I had a place. So that kind of didn't really help with my academic career moving forward, I suppose, and I had to really start from scratch again. I was, and I still am, a massive and an enthusiastic sports fan, and I tried to play everything with anybody and everybody who want to play with me, really. What comes with that is I'm a really bad loser, and I tend to mull over all of my performances whenever I do them. Well, it's still up to this day. I didn't realize at the time, but this really gave me some of my really first important life lessons. The team, and how important it is to be part of one, and having that support and the backing of those other people around you who have the same aims and goals, no pun intended. Having self-analysis, it's often very harsh, especially when I play badly and I'd go over things again and again in my head. I can still recall a terrible miss from point blank range, aged 11 years old, where I smashed it over the bar and we lost that game. Feedback can be very brutal, and certainly the others in that team gave me a right royal talking to at the end of that. But this develops resilience, and it helped me with making some coping mechanisms that I've continued to bring with me. I've been fortunate enough to be able to carry on being active, and despite multiple injuries, I've competed around the world doing lots of daft things, as you can see in these pictures. I'm more than happy to talk about some of these exploits if we've got time. Nurse training, when I did it, was a little bit different. You used to do 8-week placements on a different ward, and that lasted for 3 1/3 years. And my last student placement really shaped the rest of my working career. Everyone told me it would be an awful place to work, that it was depressing and it was sad and everybody died. The ward was called 7Y at the Royal Liverpool Hospital. It was a haematology and bone marrow transplant unit. And in some ways, they were right. It was often sad and an awful lot of people did die. But And here really is the massive but. The people who worked there and cared for those patients were among the best nurses that I've ever met. And I've certainly worked alongside people for a few years in different places, and I still hark back to those days in Liverpool and that group of nurses that I worked with. So I took and applied for my first qualified job, and I started working there in April 1991. And at that time, nursing was rapidly changing. We were just starting to take blood, we were putting in cannulas, and we were allowed to make up intravenous antibiotics and actually give them, although you still weren't able to give the first dose at that time, only the subsequent ones. And it sounds odd saying that out loud, that all of these now routine tasks were performed at that time by doctors. I made sure that I learnt these skills and became a trainer. And the haematology and transplant ward of 7Y was a microcosm really for the rest of my life. Seeing these new opportunities, being encouraged and supported by those more senior around me to take and develop those opportunities and influence the patient care. I tended to say yes a lot and then repent at my leisure. I found that just saying yes has led to an awful lot of doors opening. By the mid-1990s, advanced practice was taking off, and there was a course developed in Liverpool. I applied for this course, but I wasn't successful. So over the next few years, I did a lot of other things. I did other courses, I took a diploma, and then I did a degree. And I realised that the landscape for nursing was going to change, and I needed to keep up. My life circumstances changed, and I moved to and worked in Australia in 1999. And this was amazing. At the time, they were way ahead of us in the UK in terms of resources, electronic solutions, like computer-controlled medicines, dispensing machines on the ward. I felt like I was working a bit in Star Trek. It was a great experience, but we both decided we missed home and we moved back to England. So when I came back, I was offered a place on the cancer care diploma course at the MAHSC in London, another cancer-specific trust similar to that at the Christie. At the end of the course, Dawn and I then moved to Manchester. I became an apheresis nurse and a transplant coordinator in 2001, and I developed practical, clinical, as well as leadership and educational skills. And this was really my first exposure to collecting data myself and seeing how this could influence the care of my patient group, rather than being part of somebody else's projects. And as a team of 3 transplant coordinators, we collected data on apheresis toxicities, such as hypocalcemia and how to manage it, on things like sepsis, central line infections, and we introduced a needleless device for accessing lines, aiming to reduce needle stick injuries, as well as reducing the risk of infections. We wrote several abstracts and we produced posters for conferences, all supported by the great team around us. Advanced practice became a hot topic following the European Working Time Directive and the reduction in junior doctors' hours. And this time I was fortunate enough to get onto the second MSc Advanced Practice course at Salford University in 2005. This was without doubt the most stressful 2 years of my life and was only made possible from the support I received from Dawn and the team that I worked with. The learning curve was steep, and to be honest, I'm still on it, although more of a slope now than a mountain. I wasn't 100% sure what would happen, how or where I'd end up, and what would happen to me at the end of the course. I'm very much an opportunist, and it seemed a natural progression for me, as I never wanted to move away from patient care. I certainly didn't want to be a ward manager. So for me in 2005, starting an advanced practice nursing practitioner course was going to enable me to look after my transplant patients in a different, and what I hoped to be was a better way. I wanted it to be in a way that I expected would complement the team of the specialist nurses that I was leaving, but was still going to be working with and sharing the same office spaces. I was extremely fortunate to have 5 colleagues across the hospital on the course with me at the same time, and we had 6 qualified staff also working in the trust that gave us advice and support. From this group of 13 advanced practitioners in 2005, we now have 113 advanced practitioners on site, and we're still growing in number. I set up a nurse-led late effects service for allograft patients. I arranged and set up nurse-led bone marrow clinics, and I had a stream in our acute transplant clinic, as well as reviewing drop-in patients who were acutely unwell, attending our day unit, and this acted as an informal A&E service and a bridge for people to be admitted. Around this time, I attended my first International European Blood and Marrow Transplant Conference, known as EBMT, and these move year to year around European cities and have around 6,000 to 7,000 attendees. I'd attended several UK nurses meetings and found them to be okay. At a conference in Istanbul, I was expecting it to showcase nursing excellence and be able to take home wonderful ideas of how to do things better, to be better. I was wanted to be inspired by European colleagues. Unfortunately, I was somewhat underwhelmed, and I said this to the then chair of the UK EBMT branch, who told me that I shouldn't complain unless I was willing to take part and offer some solutions and make things better. So I became a committee member of the UK EBMT group and then chair for the next 10 years. And concurrently, I became committee member of the main EBMT scientific committee, then chair, and eventually president of the whole nursing group. This consists of 4 nursing committees: paediatric, global, scientific, and research. I was now in a position to be able to influence the educational direction of haematology and transplant nurses across the whole of Europe. It also allowed me to be part of multiple projects that met my inquisitive nature. A few publications came out of this, as well as podcasts, videos, book chapters, interviews, and multiple lectures at haematology and transplant meetings across the world. And I've been fortunate enough to be able to go to Moscow, Mumbai, Brisbane, Melbourne, and across most of Europe, as well as presenting virtually to Mongolia, Ukraine, South Americas, Canada, and Nigeria. At each of these talks, I've had the privilege of sharing my experience of transplant and hopefully offer hints and tips that I've learned along the way for others to use in their own practice. For me, it's important that each educational session has an impact on patient care in some way. Advice on better skin care, starting conversations about sexual health and function, how to care for patients with graft versus host disease in a different and hopefully better way. I was also keen to bring in other groups of nurses, those from low and middle income countries, and I spent time with our global committee developing education programs for India, Africa, and South America. Nursing within the society was not as high profile as it could and should have been, and was not present at all of the meetings. I was able to change this in my role as president. Nurses are now attached to every medical working party and are given a voice. I helped to develop specific nursing tracks and study days that ran alongside the medical study days. I negotiated for free access to study days for nurses from the host country that massively increased attendance and hence their educational exposure. Many nurses struggle to attend meetings due to financial problems, and most drug companies do not sponsor nursing attendance. Nursing became more visible within the society. My role with EBMT has changed over the past few years, and I'm less active as I really don't have the time within my clinical role anymore. I want to focus, though, on a couple of projects I took part in. As a haematology and transplant nurse, I've grown up as some of the major developments have been made within graft versus host disease, or GVHD. Better diagnosis, improved treatments and patient care. GVHD is common problem post-transplants, affecting up to 70% of patients, and is characterized by multisystem immune-mediated injury, fibrosis, and dysregulated tissue repair, and can mimic autoimmune inflammatory disorders. Diagnosis comes from clinical, histological, and functional assessments, and management requires a whole team approach over a lengthy time period. It can be very debilitating and has an enormous impact on quality of life for the patient and their family. This is an area where I've been attracted to, but it can be a really hard place to inhabit. I'm passionate about education and how we can improve the care we provide for our patient population, especially those with GVHD. As a group of nurses, we wrote nursing chapters in the EBMT handbook, as well as the CAR-T handbook about basic care. A colleague noted that there was nothing specifically focused on nursing and AHP care of the transplant patient. So we wrote a textbook, which as a first edition had more than 500,000 downloads and is now in a second edition. It has been translated into 6 languages and is in print and online. This describes all of the elements of care of a transplant patient, all the way from tissue typing to infection, GVHD, and late effects. And it's written by nurses and AHPs, specifically for nurses and AHPs. Working with the 4 committees enabled the production of several publications, access to treatment, safe transfer of patients, developing an inclusive society, sexual function, paediatric care, training needs, as well as, a slide seemed to have stopped, as well as patient engagement. And through these networks and groups, nurses and AHPs were able to shape and develop practices. Other media began to become more available, and I've contributed to several podcasts, mainly on the subject of graft versus host disease and its consequence. This continues really to be my main area of clinical interest. I recognised that people learn in different ways, and I obtained funding to produce some educational videos. And we now have 3 short videos on how to perform a bone marrow, how to place a central line, and how to reinfuse cells. One paper that I would like to focus a little bit more on is a joint publication between the European Respiratory Society and EBMT. It shows how a simple interaction can lead to a 2-year project that is still offering more areas of development. In clinic, I saw a 19-year-old man who was around a year post-transplant, who was in remission but really struggling with progressive lung graft versus host disease, a less common but devastating consequence of transplant. His exercise tolerance was about 100 metres on level ground. If you just think about that for a minute, 19 years old, in remission, can walk 100 metres. So we tried lots of medications and nothing was really helping. And the outlook for this patient group is really bleak. I looked to see what national, international guidance could help us with decision making. Was anybody publish anything that might offer a slim chance of stability? Are there any trials or experimental options out there? There was nothing specific I could find on a PubMed search. This made me think that maybe others had answers, or other trusts and other centres that were more anecdotal, small case series. Is there anything there? So I set up a study day and I invited respiratory and transplant haematology and respiratory colleagues from across the UK to attend. And this generated a lot of discussion at the end of the meeting of what we all do with our patient group. But nobody had any additional ideas to what we were doing here at the Christie. Everything remained very anecdotal evidence with only 1 or 2 patients. So I started contacting clinicians across the world, random emails to people I'd never met. I'd seen their names on papers and I thought, well, they know something about it and maybe they can help me out. And most people are very generous in this situation and they gave some really valuable tips, but again, nobody was doing anything that had hard data behind it. So I applied for funding from the European Respiratory Society and EBMT to support the development of a clinical practice guideline for pulmonary chronic graft versus host disease. And as you can see, we were successful. What I did was I then invited all of those people that had come to the meetings, all of those that I'd sent emails to across the world. We had a large working group, as you can see from that publication, across Europe and the USA. It took 18 months to pull this together, but eventually we had a decent guideline that is now being used elsewhere. I mentioned earlier that I have a split role, and this happened in 2023, and I took on a 2-day-a-week seconded post as the Advanced Practice Education Lead for the Trust. And this was a new post for the Trust, so I had a blank canvas to look at everything from governance structures, supervision, teaching, training, and the appraisal process. There were 67 advanced practitioners when I took the role on, and as I said earlier, there are now 113 with 26 trainees across the sites. There have been great opportunities. We've run 4 clinical study days on site. We've had 6 OSCE-style study days that I've designed and hosted jointly with Manchester Metropolitan University. And we're about to have our 3rd annual non-clinical advanced practice hybrid study day with speakers attending from across the country. In collaboration with Lancaster Hospital, we have a monthly online educational session, and there are now a framework of practice and an appraisal process. And in conjunction with an external provider, MIAD, we've had several supervision study days. And the Trust is aligned with the regional and national advancing practice programmes. And I've spoken at the NHSE annual conference on how we have developed our service here. I might have mentioned this already, but really my focus remains very firmly in teaching and training and education. So what lessons have I learnt from along the way? I've learned that you really need to make friends and make lots of them. Go meet every single one of them. If you can, meet the people that you work with in person rather than, on these screens. Make that personal connection with people. Be visible, be vocal, be an advocate. Show the positives rather than the negatives and collect as much data as you can on everything you can. You never know when it will be useful. Showcase all of the work that you do and how this benefits your patient group. Look at QI projects, service redesigns, right person, right place. Look at your research, teaching. Be on national and international committees as often as you can. Represent yourself because this represents your patients. All of this then reflects back on the service that you provide and ultimately will improve patient care and their experience. Teamwork. Be open and be honest with each other. Work through problems. Where can it be improved? Where do you fit in? How is the team led? By who? What is the education and support that we need to provide for our trainees and our qualified staff? This is all based around the 4 pillars. and it's now embedded into a framework. Use this. So what am I doing now? So I remain clinical for 2 sessions a week, following on from the pulmonary chronic GVHD guideline. An international group has been pulled together. We're currently meeting monthly to produce a series of papers on how to implement the guidance, as there's a wide variation and difference across the world. When should you do a lung function test? How often should you do them? If you're doing a CT chest, are you doing inspiratory and expiratory phases? Are you doing a bronchoscopy? The list is long of the implication practical bits that we need to look at. I've been a PI on an acute graft versus host disease national industry-led pharmaceutical double-blind study that has just recently closed. I continue to love to share and teach, and I have visitors regularly come and shadow in my clinics. And I've just hosted 2 Swedish nurses on Monday and Tuesday this week from the Karolinska Institute. And I have some lovely chocolates on my desk from them as a thank you. I'm currently updating the patient information leaflet for the lymphoma action group. And with Louise from our Christie Institute, and we have an application in for funding for a multimedia educational programme across the whole of acute and chronic GVHD for patients, relatives and healthcare professionals. And we're hoping that we do get some funding for this. In my advanced practice post, I'm looking to develop processes for providing evidence for the effectiveness of advancing practice roles in a variety of settings across the 4 pillars. And this is particularly pertinent in the current climate. I'm implementing an electronic appraisal process to offer more direct clinical study opportunities. And I want to provide a clear pathway for trainees all the way through to senior advanced practice that encourage personal development and enables retention of staff that allows for succession planning. And this will improve stability within teams and better patient care through the acquisition of knowledge and experience that is not lost when individuals retire. I'm always open to offers. So if anybody has something interesting, the answer is yes. Thanks for your time, and I'm very happy to take any questions. And by the way, that's Professor Yaffle for people who aren't old enough from Bagpuss. He's the only professor that I could think of outside of the nutty professor from Back to the Future, and I'm probably somewhere in between the two.
Yeah, I think you just went a little bit too niche for me there, John. I was wondering how Bagpuss did get his professorship, but thanks for explaining that one. All right, but thanks very much, John. So I think I just had a couple of questions that I wanted to come back to on specifically around some of the processes that you mentioned around the graft versus host clinical guidance. Yeah. So what were there any of the major challenges you ran into with bringing together such a big working group for the study day and for the following subsequent work?
Yeah. The study days are really easy to pull together, to be fair. I've been doing this for such a long time. They're quite easy. Come up with a title, think of a speaker, keep pestering the speaker until the speaker says yes. That's easy. The hard thing is getting a room, finding somewhere to do it. So that bit was easy. And then once we've got people in a room, at that study day, the idea, we had a series of presentations talking about the history of lung GVHD, any hints and tips that we could get. It was really good listening to others from different professions. So our respiratory colleagues were talking about how they had different approach to what we do in hematology, and that was fascinating to listen to, because that then made me think, well, if they're doing that, how do we sort of gather that together and make that into something? So that group, then I sat down with one of the clinicians from Oxford and said, all right, how can we get this and work this into a guideline? So she's like, okay, think about who are the people that are important, hence my random emails to people across the world. And that got them interested, because I said, what are you doing in your practice? And everybody was doing something anecdotal, or they were doing it off their own personal history of looking after GVHD patients. And what we all want is to have a guideline, something to follow. So getting people interested, again, that wasn't difficult. I think the process of getting the funding, that was difficult, applying for that through, and that took 6 months to get the funding sorted. We met online because people were across the world. So meeting at daft times in the morning and daft times at night to accommodate people from the East and West Coast of America. That was harder. Writing it took a long time to write it and get that right. And myself and Saskia Boss, joint first authors on it. And that took an awful lot of effort from everybody involved in the group. But it was fun. Again, it's something that I think people need to push yourself, and you think, how is this going to impact my patients? Am I going to make a difference? It might be a little bit hard work for me to do, but it's going to have a benefit at the end of it. So I always encourage people to think about the area you're working in and what can you do to improve that?
That's great. Thanks, John. So I did have a follow-up question, which was about the structure of a study day, but I think you've already covered that in terms of getting the speaker and harassing them. So
Yeah, people get fed up of me emailing them. I think it's
yeah,
yeah, they're like, John, not again. I already spoke for you. It's like, yeah, but you were really good, so come and speak
yes.
for me again.
Exactly,
Um,
yeah. So hopefully in the future as well, John, if there are chances to collaborate on these kind of study days, I think that's the kind of thing that we at MAHSC and over at the Research and Education team at Health Innovation Manchester, it's the kind of thing we've been happy to facilitate and work with our partners in. We do run a study day for the Greater Manchester Orthopaedics Alliance, which
okay.
is happens over near our offices in City Labs at the MFT. So yeah, I think that's an opportunity to explore potentially with some
Mm,
more of the MAHSC activity picking up again in
yeah,
2026.
fabulous.
All right. Well, I think we are past our half an hour slot, so I'll just bring the event to a close. So this will be uploaded to YouTube hopefully in the next couple of weeks. And we'll keep your contact details in there, John, as well, just in case anybody does want to get in touch following the talk. So thanks very much, everybody.
Fabulous. Thanks very much.
Thanks, John. I'll be in touch about the blog as well.
Okie dokie. Thank you very
Thanks,
much.
bye.
Bye.